Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. We are back with friend of the show, our toxicologist that we always go to when we have tox questions, Dr. Sanjay Mohan. Sanjay, how's it going?
How's it going, man? How are things with you?
It's good. It's good. It's great to have you back. And not that you don't know other things about emergency medicine. We understand you are a general emergency practitioner, but we have you here for the tox. And we have a classic tox question today. It's about salicylate toxicity. We have some patients who come in and say, I downed a bottle of aspirin. That's pretty easy. It's a salicylate. We know what to do with that. We know how to progress. But sometimes figuring out that salicylate toxicity is what's going on is a little bit more difficult. And part of that starts with just understanding the drugs. Again, if they tell me they took aspirin, I know what to do with that. But there are other medications that contain salicylates where we still have to think about salicylate toxicity.
So it's essential to remember that salicylates are widely prescribed due to their analgesic, anti-inflammatory, and antipyretic properties. As you mentioned, aspirin is probably the most common just because it's easy to get and it has a wide variety of indications. But other things to remember are things called methyl salicylate or oil of wintergreen, which has been used topically as an analgesic, and bismuth salicylate, which is found in Pepto-Bismol.
Yeah, so someone says they drank like a bottle of oil of wintergreen and doesn't sound so bad. You're like, great, you're going to be minty fresh. But actually, that's a very toxic agent if you take enough of it. So we just have to be keyed in to the other possible salicylate sources. Again, it can be a little bit difficult to know that we're dealing with toxicity. So what are the key features in the presentation that makes you say, oh, this is an acute salicylate toxicity?
So acute toxicity generally begins with nonspecific GI symptoms. So things like nausea and vomiting due to local gastric irritation. Some patients may present with ringing in the ears, tinnitus or tinnitus. I'm still trying to figure that one out. It's funny to know historically that physicians used to prescribe aspirin and tell patients to take enough until their ears started to ring, and that's how we would actually titrate those medications. Salicylates also directly stimulate the medullary respiratory neurons, which means patients may present with tachypnea and or hyperpnea, so fast breathing and deep breathing. Hyperthermia can also occur secondary to uncoupling of oxidative phosphorylation. But honestly, that's generally considered a pre-terminal sign. So if there's no other reason for the patient to be hyperthermic, you should be worried. And then as the acidosis worsens, grave clinical consequences ensue. Things like cerebral edema, coagulopathy, and acute respiratory distress syndrome.
That hyperpnea with clear lungs, that's a kind of one of these classic presentations where we think about aspirin ingestion or salicylate ingestion. It's not super common nowadays. We don't see a lot of salicylate toxicity in the US, but it's something to keep on your differential. When you see that patient who looks short of breath, but their lungs are crystal clear, there is a salicylate lab test. The question is, who should we be sending it on? Because I can't just send it on everybody who comes in. So I got to pick a specific subgroup. So where do you recommend that we get that test? And then what numbers are important for us to remember?
I think if you ask most acute care clinicians what tox screening labs are, they're going to be sending acetaminophen, ethanol, and salicylate. And there's a reason we do that. Those xenobiotics are common, easily accessible, and have a high degree of pretest morbidity and mortality. So salicylate should generally always be considered for your screening tox labs. Otherwise, if a patient is tachypnic, has clear lungs, and has an anion gap metabolic acidosis, I think it's totally fair to send it as a screening blood test.
In any patient with overdose, we are going to send a salicylate level, understanding that there are co-ingestions and also understanding that the patient might not report taking a salicylate because it was mixed in with something else that they took. So sometimes we get a false sense of security based on the history. If we get that number back, what number makes us say, I'm really worried, I got to get my toxicologist on the phone right away?
So a therapeutic concentration is anything between 15 to 30 milligrams per deciliter. So at a baseline level, I would say if it's higher than 30, you should consider toxicity. As you get higher, it's obviously scarier. Anything greater than 100 generally warrants hemodialysis. And even once you get above 70, you got to think about other means of elimination.
That's a good segue into management. Dialysis is a little bit at the end of the line. Let's take a little bit of a step back and start with some of the earlier things. What's the role for things like charcoal or GI decontamination?
So for the patient who's awake, alert, and can otherwise tolerate PO, please give activated charcoal. Salicylates adsorb well to charcoal. And more importantly, aspirin in particular has a propensity to form bezoars. Bezoars are just concretions that stay stuck in the stomach and can create long-term absorption well beyond the acute period.
Even if the patient had the ingestion hours ago, we're still going to give them charcoal as long as they can safely take it, because we just don't know exactly where we are in that absorption based on things like Bezors, but also things like the longer acting preparations, the ones that are delayed release. So there are a lot of different reasons to give that charcoal if we can. What about an antidote? Do we have a specific antidote? So I send the aspirin level, it comes back as 80 or 90 or 100, or the patient just doesn't look well. They've got that big anion gap. Is there something that I can give that is rapidly going to fix this?
So we don't really have an antidote, but we have a means to enhance elimination. Without getting too far into the weeds, we want to keep salicylates in the serum. Salicylates in the serum in and of itself aren't bad, but once it gets into tissue, specifically your brain and other vital organs, that's when you should be worried. So we enhance elimination by alkalizing both the serum and the urine. And we do that with our good old friend sodium bicarbonate.
How are we doing that bicarb administration? Is this just bolus dosing? Is it just infusion? Is it a combo of both? And what's our target with that therapy?
You should start with a bolus dose, 1 to 2 milliequivalents per kilogram bolus, and then followed by an infusion at 1.5 to 2 times maintenance. The goal should be a urine pH anywhere between 7.5 to 8.0.
These patients are often altered. Is there anything specific about salicylates in terms of altered mental status management that we have to keep in the back of our heads as we're treating these patients?
So there is a phenomenon known as neuroglycopenia when it comes to salicylism. And what that means is that despite a normal peripheral blood glucose, essentially you may be hypoglycemic, as in low glucose in your CNS. So I would say in the patient who's altered and salicylism is on the differential, I would empirically give 1 to 2 quote unquote amps of D50 to see if they respond.
And is there a target glucose that we should be shooting for in the serum, or is it just let's give them some glucose and see how they do?
I would say give them some glucose and see how they do, but you definitely want them to be above normal, above 100.
We talked about dialysis a little bit based on that level of 100, but there are other indications. So what are our indications to move towards dialysis for this patient?
Indications for dialysis include a concentration greater than 100 milligrams per deciliter or greater than 90 in the context of renal dysfunction. Salicylates are removed via the kidney. So the greater the degree of renal dysfunction, the lower the threshold for hemodialysis. Moreover, if you can't excrete in the setting of optimal bicarbonate therapy, you should have a low threshold to consult nephrology.
And I think one of the essential pieces here is that if you have a sick patient with salicylate toxicity, get your renal folks on the line, get your toxicologist on the phone. You really want them talking to each other to make these decisions or help these decisions move forward. It's really very nuanced in when we are going for hemodialysis, when we're not going for hemodialysis, and getting your consultants together to make that decision is really helpful. So I like getting my toxicologist involved early. They often will be like, call renal now. We're not going to dialysis right away, but I might need them. I'd rather that they are aware of the patient early so that when we need to go there, they're already ready to go. So I think those are some really useful tips. You know, we often say, get your toxicologist involved early. I'm just going to say it one more time. Get your toxicologist involved early in these cases. They are your best friend in managing these patients. And then I want to close up with one really important management point, which is avoiding intubation. The classic answer, should I intubate this patient with aspirin overdose, is do everything you possibly can to not intubate them. And Sanjay, I just want to ask the question of why? Why are we worried about intubating this patient? And if we do have to do it, how do we do it the right way?
So this is a complicated but incredibly important point. Recall that aspirin induces, or salicylates in general, induces central tachypnea, which means they're going to be breathing pretty quickly. But as toxicity worsens, there's also an underlying metabolic acidosis. So the way I frame this is kind of think of this in the same bucket as your DKA patient. They are breathing at a rate that's really hard to match when you put them on the mechanical ventilator. So if you absolutely have to intubate these patients, you got to optimize first pass success. The most senior physician should probably be intubating, maybe an awake intubation with ketamine, and some peri-RSI bicarbonate may also help.
And I'm just going to alter what you said about the most senior physician to the most experienced physician with intubation. So it's the person who is going to intubate the fastest because we want to eliminate the apneic period as much as possible. And honestly, we could talk forever about intubating the patient with metabolic acidosis. It's really a topic for another discussion down the line, but minimize that apneic time and then match their pre-intubation ventilation with your vent, which can be tough to do. So call in another expert. Get your respiratory folks to the bedside to help you to titrate that vent to the right place for that patient. And Sanjay, before we finish up, let's hit everyone with some big take-home points.
Salicylates are a commonly used and widely prescribed xenobiotic due to their analgesic, anti-inflammatory, and antipyretic properties. Common preparations include aspirin, methyl salicylate, and bismuth subsalicylate. Salicylate toxicity should be considered in the patient with tachypnea, clear lungs, and some degree of acid-base disturbance. Mainstays of management include GI decontamination, serum and urinary alkalization, electrolyte repletion, and hemodialysis. Avoid intubation if possible. Given the increased minute ventilation of severely poisoned patients, any degree of apnea and resultant decrease in pH may lead to peri-intubation cardiac arrest.
That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. In the meantime, don't forget to pop on over the site, check out all the great post from our faculty, and until next time, stay safe.